So BHLink is, we're a partnership between Horizon Healthcare Partners, which is who I actually work for. Horizon Healthcare Partners is a consortium of 5 community mental health agencies, including Community Care Alliance, which you see there. Community Care Alliance actually, that is who staffs all of BHLink. So I'm sorry, I am getting an Adobe message while I'm doing this. I apologize. And also we share with, we are a grant program through BHDDH, which is the State Department of Behavioral Health Care, Developmental Disability in Hospitals, and that is the State Office of Mental Health, essentially. BHLink is a 24/7 triage center. So we're actually a 5-year grant program. So we are moving into our 4th year. But we are a stand-up center in East Providence, Rhode Island. We're over near Providence, the Country Day School and the police department. And we are open 24 hours, 7 days a week. And the whole idea is that we're like an emergency room, but for behavioral health. Many times when somebody would be having a behavioral health crisis, they might go to a traditional emergency room. We're very different. And Marissa, when she speaks about the clinical aspects of BHLink, she can speak to that a little bit as well. But BHLink, all we do is mental health care. So while if you were to go to a traditional emergency room, you might be surrounded by other people that are there for a variety of reasons. The only thing that we do here at BHLink is mental health care. So we are very much focused on that. We also run the National Suicide Hotline. So whenever you see that 1-800 suicide hotline, we answer all of the calls that come into Rhode Island through the National Suicide Hotline are answered here at BHLink. And we're very proud to say that we actually received recognition from the National Suicide Hotline. We have answered the highest call rate in the country for the suicide hotline. We're answering 99% of every single call that comes into our center. So we're really proud of that. We also run what's known as the state's warm line, which is 942-STOP. That is a phone line that people will call if they're looking for sober housing, and the state has a specific grant. When they call that number, our telephone operators will help them with getting onto that grant for sober housing. And the crisis line, which is 414-LINK, is the phone number that people will call to triage over the phone. And what our call screeners will do is sort of discuss whether or not it's something that we could talk about over the phone, whether or not it would be appropriate for people to come into BHLink. But again, we are an alternative to going to a traditional emergency room. The other programs that we also have are, we call it the Mcast program. So that is mobile clinicians. And we also have a SOAR program, which is the state opioid response. Those are actually mobile treatment teams that can go out into the community and see people in the community on an as needed basis. So a lot of the reason why BHLink was first instituted, it really was the brainchild and the baby of Gina Raimondo, our former governor. We wanted an alternative to emergency rooms for several reasons. One, emergency room care is very costly. It's not efficient for people. In many cases, when someone goes to the emergency room, they're seen, they're screened to make sure they're not a danger to themselves or others, and then they're sent home really with no real resources or follow-up. Law enforcement and first responders are also looking for help and alternatives when they're working with people that are having a behavioral health crisis. So we see people that are 18 and older. We don't see anybody under 18, and we're a completely voluntary program. So someone would not come to us because they're being forced to come to us. You sometimes hear people talk about someone who's been SERDed, meaning that they're forced into some kind of mental health program. We see people on a voluntary basis. What I also say with that is because we have clinicians like Marissa who are licensed clinicians, if somebody does come here and they are seeming like they're presenting to be dangerous to themselves or others, we do have the ability to mandate that they go to the hospital, but we try not to do that. What we really want to do here at BHLink is treat people where they are and where they hope to be going in their program. And whether it's a mental health issue or a substance use issue, we're not trying to force people into treatment. We're trying to guide them into treatment. So that is what the state created BHLink for, was to be an answer to the overwhelming admissions into emergency rooms, to fill those gaps that are happening in emergency rooms, to strengthen the state's response to the opioid crisis, and to really help people get appropriate care for their mental health issues. So, those are all the things that I had said earlier. And I can talk a little bit. This is exactly where we are. So we're in a very unassuming building. You would enter around the back. People aren't going to see you walking in from the front, so it's very private. When people enter our doors, they're met, the doors going in are locked, but we're not locked to leave. So if somebody's here and they're sitting in one of our bays and they're thinking, it's really time for me to go, they can get up and leave. We're going to try to encourage them to stay and try to see what we can do to help them, but we're not forcing anybody to stay here. And then when you walk into our center, the experience is very different. You're met by a peer. I always say that peers are some of the most important people in our buildings, because they are people that have a shared experience, either a shared substance use experience, a shared mental health experience, whatever it is, but you're met by that person. They'll talk to you a little bit while you're here. You'll next be screened by a nurse. During COVID, we've been temperature checking everyone, symptom checking everyone, and make sure that someone is appropriate to be here. Marissa can speak to this a little bit too. There's really only 2 instances where somebody wouldn't be appropriate to come to BHLink. That would be if they actually are presenting with physical symptoms that sort of supersede what their mental health need is, or if they are being physically violent. We can handle the verbal, angry stuff. We can kind of manage that. But if somebody is physically violent to themselves or others, that would be a situation where if they were here, we would have to arrange for them to get to the hospital, because that's not the level of care that we're providing for people here. But then once they're screened by the nurse to make sure that they're appropriate to be here, we have separate bays, and someone would go into the bay where there's a chair, a television screen. It's very quiet. It's very dimly lit. Sometimes we have aromatherapy going. It's not the bells and whistles and the bright lights that people are used to in traditional emergency rooms. It's a very different experience. And we think it's a better experience, particularly if somebody is having a mental health crisis. They don't need all of the other stimulating things happening around them. We want them to be calm, and we want them to be ready to talk with a clinician, which is what the next step would be after they're screened by a nurse. They would then meet with a clinician to try to figure out what their next level of care would be. And Marissa's going to talk about that a little bit more. So the data that we have is not completely updated. The state does collect data. I'm trying to work on getting some more updated numbers. But as you can see here, these are the variety of reasons that people are visiting us. One thing that I found particularly striking is in our clients that are coming to see us that are 60 and older. They are coming predominantly for substance use issues. At least in our last round of data that we collected, probably around 2019 that I had looked at, the predominant reason why people 60 and older were coming was not for mental health issues. It truly was for substance use issues. My role here at BHLink is a coordination with the Office of Healthy Aging. And what I do is I help the clinicians that are here in trying to maybe figure out a next best placement for somebody in their journey that's 60 and older. I also work with the state's community action agencies and adult protective service to help them triage their more difficult clients that are presenting with mental health and substance use issues. I also go out into the community pre-COVID, and hopefully starting up soon next month, I'm going into senior centers, high rises, assisted livings, nursing homes, and really talking with clients that are 60 and older about mental health and trying to break down the stigma. And the aura of mental health really is just sort of things that people don't talk about, especially in our older populations. When I was going out into the senior centers, I can remember one woman saying, we had this aunt and she was just crazy Aunt Betty. And everybody said, oh, don't sit next to her or talk to her. Aunt Betty probably had an untreated mental health issue or an undiagnosed mental health issue. Somebody else talked about, their uncle, my mother always said he drank too much. And so as we're sitting there and talking, they're realizing, wow, these are what mental health issues are. So it's really been a wonderful opportunity for older people to really talk about mental health, both for themselves and for others, and start demystifying it and breaking down that stigma. So as you can see at the top, this is the traditional community crisis flow. So we get people, we get first responders, right? Somebody is having an episode out in the community, and unfortunately the police will be called. And the police, sometimes they are trained, but they're not really trained in the same way that our mental health clinicians are trained in how to handle these things. Sometimes family is going to bring somebody. A mental health or a social worker might. There's other crisis call lines, there's mobile outreach. And so all of those people have traditionally just filtered into a hospital emergency room. And then they're sort of put out there. We always hear the stories about, well, so-and-so was at the emergency room and 12 hours later they were sent home. And then 2 days later, they ended up back in the emergency room. We're hoping to break that cycle here at BHLink, because once someone has met with the clinician and we've determined what their next level of service is going to be, do they need to go to the hospital? Some people will. Are they looking for a clinician? Are they looking for a psychiatrist? Did they just need to talk to someone? Are they looking to go into treatment for a substance use disorder? We're going to try to figure out what that next best situation is. And we're going to follow up with people to make sure that they made that appointment. We don't offer treatment here at our facility. We're not a treatment facility, but we are going to make sure that people are getting that next step that they need. And we're going to follow up with them to make sure that they actually got there. A lot of the things that we've been facing this year, particularly in COVID, and particularly with the clients that I serve that are 60 and older, we've seen homelessness, we've seen social isolation, and we've really seen an increase in mental health issues that have really been exacerbated. And a lot of that all stems from social isolation, one, but if somebody isn't getting the treatment they need or having the conversations with the clinician that they need, those mental health issues or substance issues are just going to continue to grow. And so we're hoping that we as a facility can be out in the community and trying to help people of all ages to break that stigma so they can get the help that they need. We have a lot of materials. Prior to COVID, we were out at every place that would allow us to have a table and we could talk about BHLink, we were there. And the big message that we wanted to get to people was that you are not alone. People have this idea in their heads sometimes of what someone with a mental health issue looks like. It looks like us. It could be anybody. We don't know. And part of the reason why we don't know is people don't talk about it, right? If you've got diabetes, you have no issue with telling somebody, oh yeah, I'm going to take my diabetes medication. But when was the last time that anybody said to somebody, oh yeah, I really need to take my citalopram to make sure that, my depression doesn't increase? People would sort of give you a look. We want to break that stigma. We want people to start talking about mental health in the same way they would any other health issue that they're facing. That's the only way that people are really going to start to reframe their mind and reframe their thinking about what mental health truly is. Someone asked me last week, do you think you've saved lives? I know we've saved lives. I can say that without a doubt. Last year before COVID, all of the networks in Rhode Island, including the PBS networks, ran a program called It's Okay Not to Be Okay. And that's our mantra. It's okay not to be okay. During May as Mental Health Month, I think all of us say it every single day. We had an interview with one of our very early clients. She was one of the very first people that came here. And she was a mom, married, a few kids. She'd had a history of depression. And she just got to a point where she was really thinking about committing suicide. And her husband did some research. He found BHLink. He took her here. We were able to get her into a treatment program. And she will tell anybody that will listen that we saved her life. It's a different type of treatment that we have here. So as I had said again, my role is in partnership. It's a grant also with the Office of Healthy Aging. And we provide triage services here at BHLink, support for adult protective service at OHA, providing support for community providers such as senior centers, nursing homes, assisted livings, police departments. I'll frequently have, police that will call me and say, they did a wellness check on a person who was over 60 and they needed some information or some resources. I have family members calling me, children calling me for their adult parents. looking for information, looking for help. I'll even have older people themselves giving me a call to talk about these issues. Sometimes it is appropriate for them to come to BHLink, but in a lot of cases, people of certain age brackets don't want to go into a place. So I try to work to see what can I do in the most effective way to get them the care that they need. And as I had mentioned, I help to also offer presentations to older communities with regard to demystifying behavioral health. So I don't know if you want to open it up to questions now, or if you would like Marissa to be able to give her presentation and then do questions after.
Yeah, let's do that. Let's have Marissa talk and then we'll take questions at the end. Thank you. So Marissa, you're on, and if Stephanie, you could help Marissa share her slideshow.
Yep. Thanks, Stephanie. A lot of my slides will overlap with what Stephanie presented, so we'll probably just pass right over those, and I can talk a little bit about more of the specifics relative to the clinical services that we offer here at BHLink. Something I kind of just wanted to highlight that Stephanie said is essentially we really are, our goal is to be hospital diversion. I'm really excited to be able to present today, especially having it be Mental Health Awareness Month. We've been getting a lot of requests to present, and I think that's great because it is kind of breaking down those barriers and, normalizing some of these experiences that people are going through. So we can kind of skip some of these first ones, Stephanie, because these are all some of.
Tell me when you want me to stop, Marissa.
Okay.
You can see my screen, correct?
Yep.
Keep going.
It's still showing the first slide for me.
Oh, is it? Hang on. Let me stop the share for a second. It's still on the first slide. Is that what you're saying?
You stop sharing so we can't see it.
Oh, hang on. I'm sorry. Okay, hold on. Share screen. Shift.
Sometimes these things are a little tricky.
Is it there yet?
It's here. It's on.
Okay. Are we there?
Yeah.
Okay. Are you, am I moving to the second screen?
No.
No.
It's saying sharing is paused. Bring your shared window to the front. Hold on. Let me see what that means. Hold on 1 second. I'm sorry.
Okay.
Do we have music to play? The background.
Sing,
probably, you know what? I probably know it off of the top of my head. So if you guys are fine with me talking, I can do that too.
That's fine. That's fine.
So thank you, Stephanie, for giving such a great, overview of BHLink and the services that we provide. From a clinical standpoint, something that a lot of people don't know about us is that we're staffed by a master's level clinician and a nurse 24/7. So it doesn't matter what time someone comes in, they can come during the day, they can come at night, they're going to get the same level of care, which I think is really valuable. Because sometimes, you never know when people are ready to access treatment or are in need of support. So we are 24/7. We're a walk-in service. So anyone can come in anytime. Anyone can call our crisis hotline anytime, and they will get a phone screen at 24/7 as well. So as Stephanie mentioned, individuals will sometimes call us just looking for resources. Can you help me find a therapist, or are there any, psychiatrists around in the area? Or sometimes people are calling in crisis. So we're able to support them over the phone and then identify what's next. And essentially we do try to get them into BHLink because we're able to provide that assessment for them and then identify what the most appropriate level of care would be. And
as on that, Marissa, I'm sorry.
Yes. Yep.
Okay. Just tell me when you'd like me to stop. I'm sorry to interrupt you.
That's all right. You can keep going. And you can stop right here. Okay, so I'll talk a little bit about our team. We have a very big multidisciplinary team, which is such an asset because we really have a lot of people that can wrap around an individual when they're coming in for treatment. So we have registered nurses, master's level clinicians, we have a nurse prescriber and a psychiatrist that are here 5 days out of the week. We have a great, huge team of crisis phone screeners. We have peers, case managers, behavioral health workers, and transportation specialists. So something Stephanie and I had talked about really wanting to highlight in our presentation as well is a huge barrier that we've seen in the past. It's just people not being able to access treatment because they don't have transportation. And here at BHLink, we have transportation specialists available who can not only go out into the community to pick up individuals and bring them to BHLink for assessment, but we're also able to bring you wherever you need to go after here. So if you're just going back home, we can bring you back home. If you are requiring higher level of care or are going to enter a treatment program from us, we'll bring you to that program as well. Criteria for admission to BHLink, we do serve adults 18 and older, individuals who are voluntary to treatment. As Stephanie mentioned, we would never force anyone to come here. We want this to be a really positive and collaborative experience. And, being voluntary to the program is like the first step in that, being able to happen. No aggression, as long as you're medically stable. We are not as extensive in terms of medical care as a hospital would be, but we are able to provide nursing care. So as long as there isn't anything major physically or medically going on, we can provide you service here. And in terms of the services provided, we are, as Stephanie mentioned, Crisis Center for Mental Health and Substance Use. So it could be anywhere along the spectrum of needs. If you feel like you are in need of support, if you feel like you're in crisis, even if you have any questions, we'll be able to help you either via phone on our crisis hotline or here in our facility. The spectrum kind of starts from outpatient services to, hospitalization, and everything in between. There's just a huge array of services that are available in the state. So it really is our goal to complete the assessment, identify what that level of care is, and really work collaboratively to make those referrals and connect individuals to treatment. And some of these bullet points are just examples of some of the things that we are able to provide here at BHLink. A huge component of our treatment here, which, in my past experience, I've seen it always be a barrier, is just really great coordination of care. So as a part of individuals' time here, we really work on making sure everything that needs to happen and be in place happens before people leave. So if someone is coming in and they're presenting with in terms of mental health supports, if they are requiring referrals for treatment, we are doing those referrals here. We're kind of eliminating that barrier of, not being able to be motivated or having there be barriers or whatever level of intimidation there is outside of here. We want to make sure that we have a process put in place before individuals leave. So let's say a client, is meeting criteria for outpatient counseling. We will try and get that first appointment made before the individual leaves. So that's one less step that you have to take care of after you leave BHLink. We also have Kodak on site here at BHLink, which provides medication-assisted treatment for individuals. So if someone is coming in and they are struggling with substance use, we're able to loop in Kodak clinicians who can provide a consultation service and assess if medication-assisted treatment is something that they're interested in. And as I had mentioned previously, we have nurse prescriber and psychiatrists here the majority of the week. So there's also the opportunity to assess if medication management is something an individual is interested in, and also kind of start that process, as well as answering the National Suicide Hotline, the 942 stop calls, as well as our crisis hotline. So something Stephanie had mentioned earlier, which kind of links into the transportation piece, is our Mcast. And I figured that would be a good opportunity to have a service spotlight on that. BHLink has always had a mobile capacity. We've just really strengthened that over the last few months. So you may hear about Mcast a lot, and that is our mobile crisis assessment stabilization team. Essentially, that is a master's level clinician who's partnered with an EMT, and they are dispatched from BHLink and can go anywhere in the state to provide community outreach and support. So they can, provide crisis assessment, stabilization. If someone is interested in services, but maybe is a little ambivalent to coming into our facility, we can dispatch Mcast for them to go out and check in with the individuals. Sometimes that's less threatening for people. And we've seen really great success with that in our Mcast team, being able to kind of have like home visits with individuals, maybe, once or twice every few weeks, just to kind of keep tabs on them and then continue to assess, if they are requiring higher level of care or if they are interested in coming into BHLink for a formal assessment. If anyone has any questions regarding that, you can always call me. I have my number on here, but you could always call the 414-LINK number, which is our crisis hotline, and you can get in touch with me that way as well. And as I mentioned before, we're 24/7. The best way to access services, you can call, you can come in. We are located in East Providence, 975 Waterman Ave. Our entrance is in the back of the building. We're 24/7. Providers can refer individuals to us. If family members have questions, they can call in and receive support, or individuals can call or self-present at any time. Stephanie is such a great asset to our team. Anytime we have individuals who are, 60 and older, Stephanie is really able to help wrap around them and provide just another layer of support, which has just been phenomenal for us. And we're a really great team. We're really excited about some of the new things that are happening here at BHLink. And again, just trying to break down some of those barriers in accessing treatment.
That's great. Thank you both. That was so informative, and it's really sad that I really didn't know about BHLink until I met Stephanie last year, and I think it's just a great value to the community to have a triage facility like that. And as you said, it really helps with folks going into the emergency room and all that, and especially during COVID, I'm sure that that they had their hands full. So having a facility like BHLink is again such a value to the community. So now we'll open up for some questions. We already have one that's in the and I see that, Shirley. Let me just get to the one that's in the chat. And the question is, what are the recommended most effective treatment for alcoholism, substance abuse for seniors? I don't know if you're able to answer a kind of that broad statement on that. Would that be?
I can't really answer that. So I'm not clinical. And I think that would be something, I don't know if Marissa has any suggestions on that, but I'm not aware of anything that is really geared more towards older adults. But I know, any prescriber would have to be very careful and take into consideration any other medications that someone was on when considering somebody who wanted to taper off of alcohol or somebody that wanted to get into treatment. Obviously other medications or other comorbidities would really need to be taken into consideration. As far as what a most effective means would be, that, not being clinical, that isn't something I would necessarily feel comfortable answering.
So I would say that in my experience, there really hasn't been any barriers, thankfully, in making referrals to substance use treatment based on age. Typically, when we have individuals coming in who are looking for treatment for alcohol or any other kind of substance use, they're typically meeting criteria for crisis stabilization level of care. And there are a few crisis stabilization units in the state. One is run by Community Care Alliance. It's called the Acute Stabilization Unit. It's located in Charlesgate. They will actually start individuals in the detox process if that's warranted. There are also some other detox programs. Roger Williams Medical Center has an inpatient detox unit, Phoenix House, AdCare. Those are some of the more long-term start with detox and then facilitate into residential placement. Again, we luckily really haven't seen any barriers in terms of older adults accessing treatment. We'll send the referrals, and usually it's a very swift and seamless referral process.
The only issue sometimes could be insurance. So if somebody is on Medicare or somebody has a particular kind of insurance, say that they don't have, a dual or something, that can sort of present an issue sometimes. And one thing that neither Marissa or I mentioned, but I think is important to mention, is that when someone comes here, we don't want insurance to be a barrier to coming to BHLink. So we will take people that are insured, uninsured, underinsured, undocumented. Walking through our doors, the first question is never insurance. People don't pay a dime when they come here. We do have services that we may bill their insurance for, but that's not a precursor to them coming here. The only issue would then be if somebody was uninsured or underinsured, would be what that next level of care is. And we have wonderful case managers who have, their cracker jacket trying to figure out who has what insurance and what place takes what insurance and things like that. So they certainly will work to make sure that somebody is in an appropriate level of care based upon their insurance, but we don't want that to be someone's first concern. Oh my God, I don't have insurance, or I'm undocumented, I can't get, help. No, we want you to come and we're gonna manage to figure out what we can do next for you as best as we can.
That is so good to know. Shirley, next, and then Alan will get to you. So Shirley, you had a question?
Well, that actually was, I wondered what kind of a fee schedule you had. You said you were grant funded, but is it totally grant funded?
So the bulk of our funding is through grants, but we do some third-party billing. So we do, we do have that aspect as well, where we do recoup some funds based from people's insurances. But that's not, the bulk of our funding comes from a state grant. But again, we do bill insurance, so that is part of our funding source. I think the state would like it to become a bigger part of our funding source, because the goal would be, once this grant ends, that it doesn't end. We those of us that have been involved in anything that has to do with the state have seen so many wonderful grant programs come and go. And then we end up sitting at programs like this, having a discussion saying, remember this program, wasn't that so great? Too bad we don't have that anymore. We can't do that with BHLink. Part of what we were doing, and we still continue to do even during COVID, is advocacy with the General Assembly. We have interns that come here for a variety of different programs that they're in, and we would send the interns out every Wednesday to Smith Hill and go sick themselves on the General Assembly. They would have different talking points, different topics, but these interns would be amazing at just grabbing the ear of a General Assembly member and saying, let me tell you about BHLink and why it's so important that we keep funding this program, because the goal would be that we're not just BHLink in East Providence, right? Because we know Rhode Island is very colloquial. So if you've got East Providence here, somebody from Westerly isn't inclined to say, let me drive a 50-minute drive to come get behavioral health at BHLink. So wouldn't it be wonderful if we could have a few sites, one in Northern Rhode Island, one down in Southern Rhode Island? That's the goal. We'll see where the state lands on that goal and where the desire is. But I think that we have proven to many people in the community that we're an effective option and that we're something that will need to continue to grow. Marissa talked wonderfully about our Mcast program. If anybody is involved in any sort of reading on grant materials, the state block mental health grant just came out, and one of their huge emphasis is going to be on mobile treatment. In fact, just a few months ago, the state released a study that had been commissioned by the state about mental health care in Rhode Island. And one of the big pieces was moving to a more clinical model for mental health treatment, but also mobile crisis teams are going to be so important. So we're looking at something called a Cahoots program, which doesn't actually involve licensed clinicians, but it's an alternative in triaging behavioral health issues that police calls may get. Instead of sending out a police officer, they would send out this Cahoots team, which is a mobile team, and that mobile team would determine, does this person need a licensed clinician to come in? What could we do with this person to avoid police involvement and things like that. So the state really understands the need for mobile crisis. The state understands the need for providing more funds for mental health. So we'll keep talking to everyone we can. And that's one thing we ask all of you that are listening to, is if you know a General Assembly person and can grab their ear, say, hey, we need more funds for mental health, because unfortunately every year the first place that gets cut is human services. and we need to try to break that cycle.
Definitely. Alan, you had a question.
Okay, sure. I just wanted to say though, and it sounds like you, in your most recent answer, just as you finished up, you kind of answered this question, but one of our participants, Mary Alice Smith, logged in a question in the chat, and it says, in Newport, we've learned that substance abuse, alcoholism is one of the criteria, health factors that we do worse on in Newport. Do you think there needs to be more communication outreach here? So among the places you're considering, Stephanie, is Newport one of them?
Well, we actually do a lot of work in Newport right now. One of our partners in Horizon Healthcare Partners is Newport Community Mental Health Center. So they are already sort of invested in what we're doing in BHLink, even though they're not, a part of BHLink, they are a part of Horizon Healthcare Partners. So Newport Community Mental Health is very invested in trying to do more. And I think that, Mary Alice, you're right. We need to get more communication out on the island. But we actually do have people that come from Newport, and we've even had rescue come from Newport before to bring clients here. But I think you're right. I think more communication, more outreach is needed. We have, we have different people from BHLink and myself as well that will go anywhere and speak anywhere about mental health topics. So, if you know of, Mary Alice, you listen to me once a month talk, right? So if you know of any organizations that would like for us to come out and speak, it doesn't even have to be in a clinical way. A really more, when I give the presentations, when I'm going into senior centers, I'm not really talking about more clinical stuff. I'm talking about, hey, remember that uncle you had, or remember when someone, there she goes. When someone talked about how, you had too many drinks, maybe you need to hold back. We can have those conversations. And I think communication is key. So if we need to do some more outreach, we can do some more outreach.
That's great.
Okay, I had a couple of questions myself. And one was, I was curious, in terms of how people present, do people typically come to your facility on their own by themselves, or are they accompanied by a friend or a family member?
The majority of individuals who are coming in on their own. We feel that collateral and coordination of care with providers or family members is very helpful. But once individuals come in and kind of go through like the consent to treat piece, they come onto our clinical floor, and like family members and friends aren't able to join them. So while we still collaborate with them and coordinate with them, we found that kind of just having it be an individual process, focusing on, that person and having them have a really fruitful experience with the clinician and nurse has been a really positive experience.
And if someone were to call you from a remote location and indicate that they're in trouble, do you provide transportation from where they are to your facility?
Absolutely. Yep. We have at least one transportation specialist on at a time. With the initiation and strengthening of our Mcast team, it's more than one. So not only do we have the opportunity to dispatch Mcast into the community and have a clinician go out, if Mcast is busy, we typically have a backup driver available that can go and pick up an individual. As long as they're safe, we'll even pick up people that are intoxicated. As long as they can walk and get into the van, we can bring them in to BHLink. They'll still be assessed. And because we have nurses on staff, they're able to initiate and start the detox process and monitor individuals if that is the level of care that they are in need of.
We always say that we're from Westerly to Woonsocket. So we can get somebody here, we'll work to get them here. People have to understand, if we're going out to Westerly, if we're going out to those more remote Rhode Island locations, they may have to wait a little bit. So as Marissa said, we want to make sure somebody's safe. We want to make sure that they're in a good place. It may take us a little while to get to them, but we'll get to them. But we also do have a couple contracts with some ambulance companies as well. We're working on trying to get a couple more out, like in the southern area of the state. So, but we don't want transportation to be a barrier.
I have a follow-up question to Alan's, and it's really surrounding, caregivers. I guess the first question I have is that, is there any sort of signs of what for a caregiver to know in their loved one, that it would be considered a crisis situation versus maybe it's just the symptoms or what's presenting itself would be health related in a sense of maybe the person's, dehydrated, or maybe their medications are off. I mean, so that's the first question. And then the second is, as a caregiver, you said this is that the BHLink is voluntary. So how do you get someone to, that you're caring for, make the decision to come into to you? Or what's the process involved if the caregiver is really concerned and wants their loved one to be seen by you? So that's kind of like a two-parter.
So I'll take a stab at the first question, because I feel like your question's more directed towards our older population.
Yes.
But Marissa, chime in, at any time. I think that it's a very important distinction to make when somebody is having any kind of behavioral change, to determine, especially in our older population, is it a medication change? Is it an infection? In many cases, sometimes when we start to see alterations in behavior, it could be a urinary tract infection, it could be a pneumonia. So I think if you have someone who's never had any kind of history of any mental health issue, and now all of a sudden they've got this quick onset of some type of behavioral issue, my recommendation would be get to your doctor first, get screened for any kind of medical issues going on. If it's a family member that's had a history of issues and you're sort of teetering on the edge, I think it would warrant a phone call to us. Certainly, to have that conversation. Sometimes they'll call me, if you call into the call center and they're sort of on the edge, they'll give me a call. We'll triage it together. But I would say that, again, it would depend on how quick the onset is and what the history is of that individual. Because sometimes even with our clients that have dementia, you can have an exacerbation of issues, but in many cases, those people already had an underlying mental health issue. And that's where it sort of gets to be a little bit of a slippery slope. As far as how to sort of, coax somebody into coming in, that can be a difficult conversation because, number one, people don't like to be told. They don't want to be spoken at. They want to be spoken with or spoken to. So I've always told caregivers that a great approach with people is to let them know that, Darlene, I know you're struggling and I'm kind of struggling too. If I can help you, you're going to help me be able to help you more. That's always sort of been a little bit of a spin I've told caregivers, that instead of, telling the person that you want them to get help for them, let them know that by helping your loved one, it's also helping you be a better caregiver. And sometimes that can be a good start to a conversation, because what I often find too is that, particularly in our older clients, physicians do not like to get involved. Physicians want to see the patient, they want to give you your medication, they want to send you on your way. Many doctors of older people don't want to have these really difficult conversations. And it's left on caregivers' shoulders. That burden is sometimes left to the caregiver to do. So I think starting with a conversation about how to help is the most important. And then, giving us a call and seeing, sometimes, our charm can help people too. If we can let people know that this is a voluntary program and that they don't have to stay if they don't want to, sometimes that gives people the idea, like, let me just go check it out. And they might come once and they might leave. And then maybe on that third time they come, that's the time that they're really ready to start treatment or start whatever they need. So Melissa, I don't know if you have anything you wanted to add on that.
Yeah, I think that, in terms of like the medical piece, our goal is hospital diversion, there are times where we may have an individual come in and maybe they are requiring higher level of care, but they need medical clearance first. We still work collaboratively with the hospital, so we may send someone to Miriam just to have that medical clearance done. And once that's all set, they send them right back to us, and then we facilitate the referral process for whatever the higher level of care for their mental health or substance use needs is. And that has been such a positive experience as well. In terms of the second question, I love that the caregiver piece came up, because we actually just saw this happen very recently with our Mcast team. So our Mcast team was dispatched out into the community to meet with an individual who was ambivalent about coming in. They were able to outreach them maybe like once or twice a week, again, to kind of just establish that rapport, kind of, destigmatize the outreach and support as well. but then they were also able to link up with the caregiver and provide support and services to them as well, because of kind of some of the stress and duress that they were experiencing in caring for their loved ones. So again, if there is ambivalence about coming in here, still outreach us. We may link Stephanie in, we may dispatch Mcast just to kind of put eyes on the person and do like a community-based assessment if they're open to that, and then kind of continue to have frequent check-ins with them to assess the needs and see, if we're able to kind of wrap around them and identify what would be the most appropriate level of care or services for them.
Yes, Alan.
I just wanted to follow up because this has been a really interesting discussion. It's been so informative this morning, and I think it's an area that people who have dealt with relatives who have mental illness problems or alcoholism issues, it's always a struggle from the caregiver side. One of the reasons I asked the question about how people present is because I assume if a person has gotten to the point where he or she has made the decision to present on their own at your facility, that's kind of a leg up. That's an indication that they realize they have made a self-assessment that they have an issue that they need to deal with. So often, if you're a caregiver or you have a relative who's suffering from some sort of a mental illness, that person does not want to admit that they're having a problem. And so trying to get over that hurdle and getting to a service provider it can be a real struggle for a caregiver. And so the mobile outreach program that you described, Marissa, I think is certainly a step that would be incredibly helpful. I certainly hope that your funding continues. We at AARP can identify with the interns who go to the State House on a regular basis to talk with our legislators, because of course we're doing that as AARP volunteers all of the time in our red shirts to talk with them about the things that are of importance to AARP. And this area is something that this is such a critical need. It's hard enough dealing with physical health issues, but mental health issues are consistently challenging. And just in the very brief time we've been with you this morning, we can tell how professional you are and how well-versed you are in as clinicians and service providers in terms of what you do. And you are truly God's angels on earth.
Thank you.
So we offer our thanks and gratitude.
Thank you. There was one question I saw, Darlene, from someone from Progresso Latino. We will do presentations anywhere. So I'm finally excited to say that I just got my first request to go out to a local senior center. I'm going to be heading out in July, in June and July. I'm actually, a couple of us are going out to do a community outdoor event next weekend. So we have tables, we have swag, we have pens, we have signs. We will go anywhere and participate in any activities or discussions that people would like to have us. I put my contact information in the chat. Give me a call, reach out via email. Both myself and Marissa, we can definitely organize that. Absolutely. And we're excited to be getting back out into the community.
So, Stephanie, I know the person asking from Progresso Latino. So let's talk. I know that they have a huge Hispanic population that they serve. So what are the languages that are offered to help people at BHLink?
I'll let Marissa speak to that just because she's there on site.
So we have a handful of Spanish-speaking staff that are here, but we also utilize a language line, so that if you wouldn't believe the number of languages that we have access to an interpreter. So that is never a barrier for us either. We've had great success with utilizing that line. So again, in addition to the staff we have on site that are Spanish speaking, we have Portuguese speaking staff. We utilize our language line. And again, that's also an opportunity for us to kind of link in family members and friends if we're able to, just to, again, eliminate some of those barriers, maybe even linking in some of the providers. Individuals come in, maybe linked up with some other community mental health agencies, and they have like case managers or other staff members that they have access to that can kind of support in the process. Mm-hmm. Something that didn't come up that I also did want to say before we wrap up, a lot of people ask how long people stay here. We are short term, less than 23 hours. So typically We're not an overnight facility. We may have individuals stay overnight depending on what time they come and what level of care we're transferring them to. But another positive aspect about our facility is that our wait times and our treatment times are significantly less than the emergency room and hospital settings. A few hours at most for the majority of the individuals that come in, and they're coming in and they're getting a rapid COVID test, they're getting a medical assessment, a clinical assessment, and then they're receiving referrals and recommendations as a part of wraparound services.
Yeah. And there will be times, unfortunately, the situation for psychiatric beds in hospitals in Rhode Island and surrounding Massachusetts is really difficult. So there may be times where we have somebody whose wait time is a little longer just because we're waiting for a bed for them if they need to go inpatient at a hospital. We'll work with that person. If that person doesn't feel safe, if they feel they can't keep themselves safe by going home and waiting for that bed, we're going to figure out a plan for them. We're not going to say, 23 hours, kick you to the curb. We'll work on something. But also we have literature that is in Spanish, Portuguese, and I think we also had some printed in a Creole. So we have a variety of printed materials also. I would love that. Dominga, please contact me. I'll come and speak, and I'll bring somebody that speaks Spanish also.
That's great. Well, this has been a wonderful conversation. I learned so much, and we're just, again, I can't say it enough on how fortunate we are to have this type of facility here in Rhode Island. And just to learn that you're able to go out to people is, that is so key, as we know, especially the past year that we've had to deal with a lot of folks being isolated and shut-ins, and knowing that you're able to go out to them and to help them. That is just a huge, huge benefit. Before I go any further, I just wanted to, because we had some people join us late, so I just wanted to read our disclaimer once again on this conversation. The content in this presentation, including any tools and online websites, is provided for general informational purposes relating to medical conditions only, and not intended as a medical advice, diagnosis, treatment, or as a substitute for the medical advice of a physician. You should not use the information contained herein for diagnosing a health or fitness problem or disease. Participants should always consult with a doctor or the healthcare professional for medical advice or information about diagnosis and treatment. So with that, I just want to again thank you, Stephanie and Marissa. We appreciate your time to discuss this delicate but important topic. Living a healthy lifestyle involves all facets of ourselves, physical, emotional, and certainly mental as well. This concludes our event, but please visit our lineup of events and happenings at www.aarp.org/RI. Tomorrow we have a legislative update and a healthy cooking demonstration on Thursday. So please take a look again at www.aarp.org/RI for our upcoming events. Thank you again, and we hope you enjoyed the discussion, and have a great rest of the day.